I think we'll get started. I want to welcome everyone and thank you for taking the time to attend tonight. Next slide, please. I'd like to acknowledge the Primary Care Network Board for organizing tonight's event. And I'd also like to acknowledge Nicole Biordi from the OMA and Jennifer Tran from Ontario Health for helping to put together this event. Next slide, please. So tonight, even though Omicron's on everyone's mind, we're actually not specifically talking about Omicron, but we're talking about the treatments available to minimize hospitalization and death. My name is Sohal Goyal. I'm a family doctor in Mississauga and chair of the Mississauga Halton Primary Care Network. Next slide. Prior to me doing the land acknowledgement, I just wanted to talk for just a second here. And I know, although most of us are burnt out, and today it feels like the sky is falling, we are in a better place than 1 year ago. We have vaccines and treatments. Ironically, exactly 1 year ago today, my father contracted COVID-19 in hospital, and I went into isolation myself for the next 14 days. Though he didn't survive, I take comfort in knowing we now have tools to protect our patients. As our primary care network meets here tonight, we are in solidarity with the Indigenous peoples of Turtle Island. I would like to begin by acknowledging the land on which we gather is part of the treaty lands and territory of the Mississaugas of the Credit. And prior to that, the traditional territory of the Haudenosaunee, Huron, and Wendat. We also acknowledge the many First Nations, Inuit and Métis, and other global Indigenous peoples who now call this area their home. We are grateful for the opportunity to be living and working on this land. Next slide, please. So we want this to be interactive. Feel free, the chat is open. We welcome your comments. We welcome your questions, and we have the upvoting feature turned on there. So feel free to please upvote your questions, and we'll try our best to get to some of the answers during the presentation. After the presentation, we'll try to post most of the answers on the Primary Care Network website. Next slide, please. So now I get the pleasure of introducing our esteemed speakers. First, I'll introduce Dr. Gupta. So Anil did his medicine training and family medicine training at U of T. He is a researcher, leading studies in a number of different therapeutic areas. Currently, his site is actively recruiting for Moderna's COVID-19 pediatric vaccine trial for children aged 6 months to 12 years old. He has recently lead authored a paper in the New England Journal of Medicine in October. And the paper was about early treatment for COVID-19 with monoclonal antibodies. And he also led some of this work in his own office. Dr. Chagla is an associate professor at McMaster University. He did his medicine training at Western University, infectious diseases at McMaster, and a diploma in tropical medicine from Tanzania and Uganda. He also has a master's in infectious diseases from the London School of Hygiene and Tropical Medicine. During the COVID-19 crisis, Dr. Chagla has contributed to local, provincial, and federal policy planning, and to several clinical trials on COVID-19 therapies. He has published works on COVID-19 epidemiology, testing, and infection control. He is also the medical director of Canada's first large volume monoclonal antibody clinic and has administered over 60 doses of monoclonal antibodies. Next slide. So how did this CME come about? Well, a few weeks ago, I started the first primary care-led COVID, cold, and flu care clinic with support from Ontario Health. Shortly thereafter, I attended a CME on monoclonal antibodies, and Dr. Gupta was presenting. During that CME, I was made aware that I could refer patients for treatment with monoclonal antibodies to Dr. Chagla's office, being the first one in Ontario. The following day, we identified our first positive case that met the criteria in terms of monoclonal antibody treatment, and I reached out to his clinic. And tonight, we're talking about COVID treatment. The speakers have donated their time to teach us tonight. There are no sponsors, no pharma, there's no funding. The Primary Care Network receives no funding as well. Next slide. So in terms of the current COVID-19 pathway, most of us know this, So we see these patients, they get tested. If positive, they receive a phone call from the testing site, as well as public health. It could be their primary care provider. We tell them to stay at home and isolate. If they get worse, to go to hospital. And of course, this creates a lot of fear for them. Next slide. As the pandemic progressed, we had other programs, and we have them in many jurisdictions. We have a COVID at home program now locally. And this provides more objective measures for the patients to make clinical decisions. And we can follow them on a daily basis using oxygen saturation monitors. As we progress in terms of treatments, we need to establish more pathways. And now I'll pass it over to Anil for the next slide, please.
Thanks, Sohal. So our clinic wanted to do things differently. So the 3 doctors in our office and the staff wanted to do more than just the virtual care that was usually provided for these COVID-19 individuals as outpatients. We provided home visits for concerned patients that had COVID, sometimes had to send them to hospital if we thought they were getting worse. We saw patients in the office if they could safely come in before hours to do assessments. We did long-term care outbreak assessments for COVID. In April and May of 2020, when testing was not routinely available, we did NP swabs in symptomatic but yet undiagnosed individuals. Later, we had an opportunity to do a COVID-19 clinical treatment trial, and we jumped at the opportunity. Patients were extremely grateful to be cared for in this manner. Next slide. So the current pathway that Sohal talked about really is not enough. You know, there has to be an alternative. Rather than just being told, stay home with a hope and a prayer, or wait till you get worse and then go to the hospital. Next slide. So I'm now going to show a video. It's a 2-minute video that was created in June 2021 by Dr. Fauci. He discusses therapeutics, and he nicely divides the treatments into 2 categories: modifying the host response and targeting the virus. Run the video, please.
So just updating you in the arena of selected COVID-19 therapeutics. I don't know if you can see the slide, but the first slide that said selective therapeutics is broken up into 3 major components, just to remind you that the work that has been done over the last many months to a year has been 3 separate approaches. One, to target the virus itself. And as you could see, the number of interventions listed there. The other is to moderate an aberrant inflammatory response, moderating the host. And the other are adjunctive therapies such as anticoagulants. If we can move to the next slide, which has the red circle around the 3rd bullet, that's what I want to bring to the attention of the audience, and that is monoclonal antibodies, 2 of which, the Regeneron combination and Eli Lilly combination, have already been approved for EUA. I've highlighted in blue another additional antibody made by GSK and Vir. And if you go to the next slide, 6 days ago, in a preprint server, some very interesting and exciting data has been published. And that is a randomized placebo-controlled phase 3 trial of non-hospitalized patients with mild to moderate COVID-19 who are at high risk for the progression of their disease, close to 600 people, a single 500 milligram dose of the monoclonal antibody Sotrovimab, again by GSK and Vir, reduced the risk of hospitalization or death by 85% compared with placebo. It is well tolerated, and there are no safety signals identified. And importantly, in the test tube, this antibody retains activity against multiple variants. So what we really have now are 3 options within the arena of monoclonal antibodies. Something that's important for physicians to know, that there is an important option for treating people early to prevent them from going to the hospital. This has been granted an EUA, so it's available for use, and we encourage physicians to at least consider this possibility as part of your therapeutic armamentarium. I'll stop there and back to you, Jeff.
Next slide, Nicole. Oh, sorry. Before you advance, so this slide is a little bit outdated. It was created in June, but I still thought it was useful. And now Dr. Fauci does show many treatments, most hospital-based, and this talk will be focused on outpatient treatment. The data he also showed for Sotrovimab was the interim analysis data. And when I show the data later, it'll be the full data set. Now, one important point he made is that in the test tube, Sotrovimab was found to be effective against the variants. And fortunately, that does hold true still for Omicron. Next slide. So now the bulk of the talk will be about early COVID therapeutics. Dr. Zain Chagla, Zain, will now talk about treatments, dividing the treatments, just like Dr. Fauci did, into modifying the host response with fluvoxamine and inhaled corticosteroids, and targeting the viruses with ivermectin and all the controversy with ivermectin and the antivirals. And then I will carry on with the monoclonal antibodies. Zain?
Let me take myself on mute. Thanks, Anil. So I'm going to talk a little bit about a few drugs, and the other one I will add to the list is, I can't pronounce this now, but Molnupiravir, I think it's called now, or Paxlovid, which has some interesting data that actually just got released today that I'll talk about. Fluvoxamine is actually quite interesting, as again, it's a host response inhibitor, and all of us know this as an antidepressive. But it does have selective effects against S1R, a modulator of immune response. And so, this is an early anti-inflammatory to prevent aberrant host responses. So, this was a repurposed drug. It got looked at as part of COVID therapeutics and in the lab. And so in a small phase 2 clinical trial, this was a trial of fluvoxamine versus placebo. About 117 completed the trial. There was an endpoint of deteriorations of shortness of breath, hospitalization, or a saturation less than 92%. 6 people met the outcome of fluvoxamine. Small study, but did kind of bring this to the forefront to say, as a cheap repurposed molecule, could this be used? Next slide. This was a large study that was actually done through McMaster in Brazil. The Together trial, which is also the largest study done for ivermectin, which I'll mention a little bit later. So this is a multi-platform trial. They're also testing things like metformin and aspirin as well, which are still ongoing. But they took Brazilian outpatients 18 or older with one risk factor for deterioration. They gave them 10 days of fluvoxamine versus placebo, did a lot of counseling around kind of psychiatric side effects. And they had an outcome that was a little bit strange, but they used ED stay and hospitalization, and their surrogate for hospitalization was being in ED for more than 6 hours. And based on a Bayesian credible interval, they saw a relative risk reduction of about 30%, and a number needed to treat of about 24. There's no difference in viral clearance. No difference in mortality. And again, viral clearance wouldn't be expected to change if the mechanism of action was only anti-inflammatory. It was a small number of people that died, so there was not enough to talk about mortality differences. There's no time to death, no difference in days hospitalized or days ventilated. So it was, mainly something that we consider early in patients. But there was certainly the signal towards reduced hospitalization in high-risk patients. Before the COVID-19 pandemic, the Omicron wave, I think a lot of us were, waiting for the US trials to come out and talk about it. They've gone through their interim analysis. And again, from all I know, that their interim data safety reviews have said continue the trials. So there's not any harm that has surmounted for the trials to stop. It's not clear whether or not there's a large benefit here. But there certainly is something here in that sense, and I think this is likely going to make it to guidelines soon, particularly if the U.S. trials confirm this effect. And given that it's cheap, it's easy to take, and again, as we're looking towards oral therapies, this may be something to start thinking about more and more to be putting on the top of the list. Next slide. So inhaled steroids, two large open label trials that were done in the United Kingdom. The principal trial, which is probably the largest trial done to date of outpatient inhaled steroids, looking at about 1,000 people in each arm. This was an open label trial, again, different platforms, but inhaled steroids were given to those over 65 or those over 50 with comorbidities, those with COVID symptoms less than 14 days. There was a reduction in self-reported recovery in 3 days, and a 2% reduction in hospitalization. Not significant, but people did feel better in that sense in getting this. The STOIC trial, which was a healthcare utilization outcome, looking at open label budesonide versus no treatment. Again, very small trial, but did see less urgent care ED hospitalization, lower fever, faster symptom resolution. These have to be interpreted with a grain of salt. These are open label trials, so people know they're taking the puffer, and so there might be that placebo effect introduced for the sake that people think they're getting an effective therapy, and that might make them feel better. But it's hard to ignore these effects. Next slide. And so there's two double-blinded studies, one which is reported here in cyclosinide, and the other that was also done with cyclosinide in a dummy puffer in Montreal. Both of them looked at patients in similar platforms. They didn't see a time reduction in primary outcome. This trial actually looked at time to symptom resolution by day 30 of all COVID symptoms, which is kind of I want to say a defunct outcome, given that most people do feel better by day 30. But when they started looking at their secondary outcomes, particularly ED and hospitalization, they did see a reduction in ED and hospitalization, a bit of a mixture between the two. So, again, there may be this healthcare utilization piece. The trial by Dr. Lee in Montreal did not show this, but even he undertook a meta-analysis of all of these trials. It really does seem like there may be an effect on high-risk patients. It's not clear what the number needed to treat is. It's probably somewhere between 20 and 50. But certainly, one could make the argument about symptom resolution here, and again, it may be a reduction in hospitalization amongst higher risk individuals when you pull it all together. Next slide. Ivermectin, I'm going to mention briefly, as I think this is something that needs to be addressed. So this is obviously one of the most contentious drugs to the pandemic. It started with in vitro data suggesting that there would be effects in the lab. The issue is these original kind of in vitro studies, when you applied human minimum inhibitory concentrations, you would be giving doses that would be toxic to the host. And so, the scientific community early recognized that ivermectin likely would not be a benefit at doses that wouldn't kill the host. But unfortunately, there's been a lot of observational studies that have gone back and forth around this topic. There was a large observational study showing reduced mortality that was retracted from the Surgisphere set. For many of you who remember, this was a data set that was virtually overtly fraudulent and recognized hydroxychloroquine issues as well as ivermectin issues and ACE inhibitor issues that eventually came out. And then there's several poorly designed small studies that came out later. They were pulled together by meta-analysis, and you'll see a few meta-analysis out there. I'll show one on the next slide. This is the Andrew Hill meta-analysis. So next slide. And looking at this meta-analysis, you see, the pooling particularly does show effect, but you see the trials that really do pull things in the favor ivermectin arm. And so this is the Alcazar study, which seems to be the one that pulls the most because it had the largest point estimate and the largest risk reduction that was seen. And again, the naive study below that again seems to have the largest effect size that was seen with the largest sample size. So when you look at these studies in particular, and there's been a lot of work done on looking at these studies. Next slide. The Algazar study, there's been a big publication actually in The Guardian looking through this. There were major data consistency errors. People were able to access the primary data set and saw complete imbalances. There was questions of data being copied and pasted in the data set. And then when people looked at the data set, the patient data set, there were impossible standard deviations that are being derived from it. So, even some suggestion from that data set, they were recruiting patients before the REB approval. This was actually redacted from the paper that published it and is no longer accessible as part of these studies. The naive study, which we talked about, and eventually a number of other studies that we mentioned here, there was issues with concealment, there was bias, there was mismatched placebo. Again, and when you look at some of the calculations of median things like respiratory rate, they're scientifically impossible with normal variation. So again, one of the studies that has significant issues. And so next slide, when you start taking away some of these studies, the effect size actually becomes much smaller. I will also mention the Together study, which was done through McMaster, which again, a large multi-platform randomized open label trial that was done that showed no difference between a drug and placebo. And we're talking again, thousands of people involved in this study. And so kind of when you start pulling out some of these studies that were excluded, you really don't see that point estimate. There might be a minor benefit, we're not sure, but certainly nothing with a number needed to treat that has been kind of purveyed in the media in that sense. And, again, until we get better information around ivermectin, this is not a drug that should be prescribed outside of a clinical trial. Outside of the United States, I don't know of clinical trials that are actually enrolling for ivermectin therapy, but there is a lot of misinformation that has been brought out there for this drug. And again, there's no clinical evidence right now that it supports its use in practice. Next slide. Lastly, the two new antiviral drugs on the market, Molnupiravir, which is a prodrug of a cytosine molecule that then incorporates into the viral genome, leads to kind of defective replication and kind of, viruses that are not competent to replicate. Two studies. This was the MOVE-IT study looking at people who are outpatients. Unfortunately, our inpatient study showed no difference. But, looking at these people that were outpatients at higher risk, you do see a reduction in hospitalization amongst these individuals in non-hospitalized adults, again, when started early. Next slide. And then the Molnupiravir large MOVE-IT trial was then continued to 700 people in each group. When the Independent Data Safety Monitoring Committee took a look at the trial in October, they saw a 50% reduction in placebo versus intervention. Now, I will mention the placebo hospitalization rate is higher than all of the other studies that we're going to present. And so there was always a question about what this group was. And a lot of this recruitment from the first 700 patients was from Latin America, where again, the hospitalization may be higher amongst those who are being recruited. But the drug was recommended for FDA and Health Canada and UK approval. There was a second press release in late November that actually showed, after going through the full trial in all people that were given the drug as part of the trial, they actually saw the effects were much lower, 9 versus 6% after full analysis. So about 3% absolute risk reduction, 30% relative risk reduction. There's likely some benefits still here, but in the same ballpark as Fluvoxamine. But this is a drug that will be manufactured in Canada soon, and so we will likely have access to this. It may be one to combine with something like a steroid or Fluvoxamine to kind of maximize benefit in higher risk populations while it becomes available. Next slide. And lastly, I'm going to talk about Paxlovid, which is now, again, Molnupiravir. So this is a protease inhibitor, very similar to our HIV protease inhibitors, where they break up, they inhibit the protease, which breaks up the viral polyprotein, and so kind of doesn't allow the virus to assemble correctly. This is actually given with ritonavir, which is an old antiviral old protease inhibitor we use for HIV. The issue is not necessarily the protease inhibitor piece, but it is because it inhibits the cytochrome system. And so it essentially in vitro boosts the dose of Paxlovid without having to give a higher pill quantity in that sense. And so we use this actually with many other HIV therapies. Our protease inhibitors are often given with ritonavir to actually boost the dose as compared to the actual protease effects. This is a large multi-center RCT. They looked at the drug given within 3 days, and they saw a significant reduction in hospitalization over 80%. Given within 5 days, 1 versus 6.7% hospitalization. There were 0 deaths in the Paxlovid group versus the 10 in placebo, well tolerated with minimal ADE, less than placebo. This is a drug that will likely change the market. There was a press release actually today from Pfizer looking at the full analysis of the data, and as well a subsequent trial that's running in the background where they saw that the data for day 5 actually was better. So, looking towards 80+% reductions in hospitalization that seem to be consistent even after the interim analysis, which is a good sign. And a separate trial in lower risk outpatients, so kind of everyone, where they still see a hospitalization reduction of about 70%. So, good signs. The one major thing with this drug, the fact that we can't just drop this off on people's doorsteps once they test positive, is that protease inhibitors do have drug-drug interactions. And so we have to be particularly careful for just prescribing these drugs willy-nilly and giving people advice. So things like DOACs, where the levels may be much higher. And again, if they're an AFib with the CHADS1, you probably can just hold the DOAC for 5 days, but you want to know about that. Certain statins will have increased doses with ritonavir. And so again, you might want to be telling your patients to hold statins. Seizure medications may get super therapeutic, transplant medications may get super therapeutic. So you really have to be careful. And again, this is a drug that will likely need clinical supervision to be given because of the drug-drug interactions. And I think I'll hand it over to Anil for the next slide here.
Thanks, Zain. So the goal, I'll switch gears and talk about monoclonals now. So the goal of monoclonals is to prevent the cascade of events from viral replication to inflammation and coagulopathy, which causes most of the disease. They, just like the antivirals that Zain spoke about, are effective early in the treatment course. So mAbs are effective, as I was saying, early in mild disease where there may just be constitutional symptoms, fever, cough, and usually no dyspnea at that time. They can also be effective in moderate illness where there is a lower oxygen saturation, but still above 94. And there can be some evidence either on clinical exam or imaging where there is some lower respiratory tract disease. But beyond that, they are not effective. Next slide. So now this is also an older slide, and it indicates data suggests that monoclonals may help in these ways. But now with the data I will show you in the next few slides, it is clear that mAbs reduce viral load, shorten recovery time, prevent severe disease, and reduce hospitalizations and or ER visits. Next slide. So which patients should be considered at risk for progression of their disease? Now, this is an extensive list. The first slide I'm showing here is the Health Canada list, and there'll be a next slide where it's an FDA list. Now, on this slide, you can see it's many lung conditions, so asthma or COPD, cancer, diabetes, CKD, heart disease, and many other diseases. Next slide. So this FDA list is very similar. Here, the age is defined as over 65, while in the Health Canada, it's advanced age. So there's no specific age, despite the studies being with certain age groups, but there is no defined age on the Health Canada list. Again, an extensive list. The original criteria were age-based or obesity, diabetes, cardiovascular disease, lung diseases, and then, the list got expanded. Next slide. So here's where I'm going to start talking about more detail of the different mAbs. Now, I will only talk about 4 of them, but there are others in development in various stages of development. So the first one I'll talk about is BAM and ETI. This is a Lilly drug, not available in Canada, does have EUA approval in the US. Its binding site is the ACE2 receptor interface on the spike protein. It's administered intravenously. The 2 antibodies bind to different but overlapping epitopes on that ACE2 receptor interface. Unfortunately, it appears that this monoclonal antibody combination is not effective against Omicron. Next, so CAS and IMD, otherwise known as Regen-Cov, is available in Canada, also does have EUA approval in the States. Binding site is the same, ACE2 receptor interface on the spike protein. Route of administration for treatment is intravenous. Prophylactically, studies were done with subcutaneous use. However, apparently it's also being used treatment-wise subcutaneously. It also binds to the ACE2 receptor interface on non-overlapping sites, but unfortunately, once again, not effective against Omicron. Next slide, next mAb is not a combination, it's a solo, it's Sotrovimab, and it's a study that I was involved with. It has EUA approval and Health Canada approval, is available in Canada. It attaches to a very highly conserved epitope on the spike protein, actually isolated from a SARS-CoV-1 patient back in 2003. So it's that conserved. It also is administered intravenously. Now, subsequent studies we did compared IM to IV administration, but the data is not out yet. So we don't know if going forward that IM administration might be possible. And it does not compete with the ACE2 receptor binding site. The next combination is an AstraZeneca combination. It's emerging, apparently is available in some countries in the world, I believe. Also, the binding site is the ACE2 receptor. Now, important for this combination, it can be administered intramuscularly. And when given 150 milligrams in consecutive doses, it has a long half-life of up to 12 months and can be used in prevention, especially in individuals that don't mount a good immune response. But unfortunately, once again, it seems to be less effective against Omicron, maybe not, still some efficacy, but less efficacy. Next slide. So here I'll go into more details of the trials of the different mAbs. So the first one is the BAM and ETI combination from Lilly. Again, the endpoint for all these studies will be reduced rates of hospitalization and death by day 29. So the absolute, the reduction was 70%, 7% in the placebo arm versus 2.1 in the actively treated arm. Nobody died in the actively treated arm. Viral reduction was significantly higher, 16 times higher with the actively treated group. And if you were still hospitalized in the actively treated group, you were admitted for 4 days shorter. Next slide. Now we'll talk about Regen-Cov. It is a combination, as I mentioned earlier. Now the study evolved as the trial progressed, but at the end there was 3 arms, 2,400 milligram, 1,200 milligrams, and placebo. The inclusion criteria included individuals that had symptom onset less than 7 days. The independent monitoring committee recommended stopping the placebo arm because of efficacy. Next slide. So in the primary efficacy population, the population included individuals that were obese or had CV disease, including hypertension, interestingly, chronic lung, liver, or kidney disease, chronic metabolic diseases like diabetes, and an immunosuppressed population as per investigator judgment, or age over 50. Next slide. So this drug was very efficacious. In the 2,400 or 1,200 milligram arms, the reduction was similar, 71% versus 70%. And that's 1.3% in the active group versus 4.6 hospitalization or death in the placebo group, or 1% versus 3.2 in the 1,200 milligram arm. Serious adverse events were more common in the placebo arm, and this is a common theme with any of these antibodies, that really they are well tolerated. Infusion site reactions were minimal. Next slide. The last monoclonal I'll talk about is Sotrovimab. Once again, an outpatient study. Individuals at risk for progression, similar inclusion criteria. So obesity defined as BMI over 30, chronic kidney disease, heart failure, COPD or asthma, diabetic, or this time age over 55, not 50, and symptom onset of less than 5 days. Next slide. So here we see a 79% relative risk reduction in hospitalization and death, 6% versus 1%, absolute numbers 30 versus 6. No participants treated with the Sotrovimab required high flow oxygen or non-rebreather mask or mechanical ventilation. Again, very well tolerated. Next slide. We can see on this side as well that no patients died in the actively treated group. Again, a very common theme with the monoclonal antibodies. Now, if we add hospitalizations and ER visits, then the risk reduction was 66%, and the absolute numbers go from 39 to 13. Okay, Zain, I'll let you carry on from here.
Perfect. Okay, so this is our current guidelines for Ontario, and really do talk about the only therapy that's been approved right now for outpatient use of monoclonal antibodies. And so this is for Sotrovimab and Devimab and Sotrovimab, which are the two approved compounds in Canada. And so, number one is the patient within 7 days of symptom onset. You'll notice Anil talked about the Sotrovimab trial. That was a 5-day enrollment, but given the issues of trying to run both monoclonal antibodies, that the science table had suggested a week would be reasonable considering this. And there is data from other monoclonals like Regen-Cov, which is a South Korean monoclonal, that suggests a little bit longer is still not the loss of the window. So if they're over the window, though, then they're not given neutralizing antibodies. If they have received a full recommended series of vaccination, then they could be considered only if they're immunosuppressed or immunocompromised. And so, the definition of immunosuppressed is a little bit fluid, but is really what would we be considered for the immunosuppressed criteria as part of our booster vaccine campaign. So many of those issues in that sense. If they are not immunosuppressed and had a full series of vaccine, then neutralizing antibody is not recommended. And this is really going back to the principle that patients who have a full series of vaccines plus or minus their booster have a fairly high level of neutralizing antibodies, where this therapy may not offer an incremental benefit. And certainly, in our recovery inpatient trial, there was no benefit seen in people that had pre-existing antibody positivity. And so, again, with a conserved resource, we are not going to give it to high risk outpatients, and that are even high risk outpatients that are fully vaccinated. In patients that have not received a vaccine, then they would be considered for Sotrovimab and Devimab. And again, we've been using a lot of criteria in terms of the clinical trials in order to meet that criteria, just because of the scarcity of Sotrovimab and Sotrovimab and Devimab. So looking at patients who are older than 50 or under 50 with a single medical condition, so that we make sure that we're giving the drug to people that we think are at the highest risk of hospitalization. Next slide. There's a lot of questions on Omicron. With multiple spike proteins that are affected with the mutations in Omicron, it is a concern for the monoclonal antibodies, as that's where they bind, as well as vaccine-derived antibodies. And unfortunately, the results coming out are not looking particularly great in neutralization studies. This is one that was done recently, and again, there's several others that replicate this finding. VIR 7831 is Sotrovimab, so it looks like neutralizing activity as compared to all the other variants. Seems like it's within the same ballpark. the Eli Lilly, BAM, Sotrovimab, Regenza, Castorama, Devimab, the AstraZeneca compound, only one of the two, Brie and DXP, which are monoclonals that are approved elsewhere in the world. DXP is a Chinese monoclonal antibody. And outside of Sotrovimab, that seems to be the only one that's active. So based on this data, we have largely pivoted over to Sotrovimab for outpatient use as of today, actually, just because of the fact that Omicron is representing many more of our cases, and it would be difficult to sort out whether or not they're Delta or Omicron by the time we need to administer the dose. There is studies ongoing for Regeneron, and it may be a dose issue, maybe higher doses, maybe more neutralizing. But until we get better information, we are sticking with Sotrovimab for outpatient use based on these findings. And I think the Ontario Science Table, when I chatted with them last, was in relative agreement in that sense. Next slide.
I think, Zain, that was kind of the end of the the end of the more formal presentation, but we thought we'd get to some questions and just maybe just to bring it back a little bit. So currently, we see these positive patients. They have to be ideally identified within 7 days of onset of symptoms. And that's what we're seeing at our COVID cough and cold clinic. And this is important for all of us on this call, in that, any one of us on this call may identify these patients early on. And if we identify these patients and they're not vaccinated or they're immunocompromised, we now have a therapy available. And the number needed to treat is 20 or less. And correct me if I'm wrong on that, right?
Yeah,
so
yeah.
Yeah, so
well less than 20, yeah.
Well less than 20. So a highly effective treatment available currently. Difficult to access, although that access point will hopefully increase as time goes on. Currently available in Dr. Chagla's clinic at St. Joe's in Hamilton, and some local areas as well, but that's the main clinic that I'm aware of, and correct me if I'm wrong there, Zain, right now. Right, and it's free for the patient. There's no cost to the patient, and it's 1 hour of infusion and 1 hour of monitoring.
Yeah.
So and that's it. So literally 1 hour treatment, 1 hour monitoring, and that's it. And the reason I'm bringing it back to that is just to, I wasn't aware of this prior to attending the CME with Dr. Gupta. So this is an actively available treatment in our unimmunized or not immunized patients or immunocompromised patients with a low number needed to treat that's free. And we have to make sure that we try to identify these patients, because that's definitely a barrier within that time frame. There are new medications coming. We know they've discussed Merck and Pfizer. They're not available yet. We're not sure when those pills will be available, although we think it's in the next couple of weeks. But again, the identification of these patients is within 3 days, if I'm not mistaken.
3 to 5 days, yeah.
3 to 5 days. Again, so very early on, and that's why it's so important that we try to identify these patients. So I'm going to just ask a question. Is there any community-based guidelines for non-hospitalized patients that you're aware of, Zain or Anil?
Yeah, the Ontario Science Table recommendations, do cover outpatient therapies, and really the only thing that's recommended is Castorama and Devimab or Sotrovimab. They have, a little bit of a wishy-washy statement towards inhaled corticosteroids, and I think they're going to be updating with Fluvoxamine sometime soon. I don't know if they're waiting for the last trial or they're just going to update without it.
Zain, can I quickly ask us, is there any other provinces in Ontario that have recommendations for other treatments other than mAbs?
Yeah, so BC has also recommended inhaled budesonide as part of patients that are considered higher risk based on that principal study. I think that's it of anyone that has a secondary medication outside of mAbs. mAbs are being recommended across the board, though they're the only drug that's recommended by the World Health Organization for the treatment of COVID-19 in outpatients. So, again, the barrier to get to that point is quite high. And again, it's the universally accepted therapy for early COVID-19 in high-risk patients.
And there was a question just regarding vitamin D. There's been a lot of questions about that in the media. Is there any benefit to recommending that prophylactically to patients at this current stage, other than the fact that most Canadians have low vitamin D to begin with?
Yeah, I think that's it. There's obviously a lot of confounding in vitamin D studies. It often is a marker of poor health status. So, we it's hard to separate out natural stuff. If your patient's vitamin D deficient, it probably doesn't hurt, but I wouldn't necessarily invest a lot of stock in it as a large scale preventative measure.
Okay, thank you. And there's a specific question about COVID-19 treatment in those patients with diabetes. Any particular difference from your standpoint?
So diabetes is considered a condition, a risk for progression of illness. So absolutely, they would be higher risk.
And just a question specifically about your clinic, Dr. Chagla. What are you offering infusions 7 days a week, 5 days a week, and how busy is the clinic currently?
Yeah, so large scale, we've been doing 5 days a week. We do have weekend hours for people that are going to fall out of the window or very high risk immunocompromised that we will give on the weekend and prioritize them. It's been variable. We've had weeks with about 20 patients. We've had weeks with 8 patients. I think now as more people are getting COVID, unfortunately, and more people are hearing about the clinic, we've been able to offer more, but we have the ability to take 10 to 15 a day, and again, a few on the weekends if we need to, if patients are falling out of the window or are very high risk.
And I can speak to in terms of referral, just for those, there's a question about that. I've referred 2 patients so far from our COVID cold and flu clinic. The team is very responsive, and the way we approach it is just notifying the patient that they qualify. So we screen that patient based on the criteria. The referral form is available online, and we can send it to everybody, and a link to the St. Joe's website that explains everything quite nicely. There's a link on our website to the St. Joe's website as well, and we send patients there for information. We don't go through a lot of details with them, just letting them know that this treatment is available to them. And our experience has been that the nurses have been phenomenal. They reach out to the patient pretty quickly and explain the pros and the cons, and then the patient can decide in terms of whether or not they want to go ahead with the treatment. Of course, a barrier is identifying that patient within that 7-day window, and the other barrier is getting that patient to St. Joe's in Hamilton. And so as things progress, there are meetings currently ongoing through the ministry and Ontario Health to offer these treatments more widely. As physicians, it's our job to continue to advocate for these treatments locally, to make that barrier really low, as we know that a lot of these patients who qualify for these treatments are the same patients, of course, who didn't get vaccinated. And so they may not have the means necessary to go to St. Joe's in Hamilton.
So Hal, I just wanted to add here quickly that, nowhere does it get captured how these people feel after the treatment.
Mm-hmm.
So, Zain and I probably treated more people in Ontario than anybody else with mAbs. And really, so there are no significant adverse events, I would say. And people feel great. Like within 24 to 36 hours, there's a complete turnaround. People feel energetic. Their breathing is better. They're much better. They're usually afebrile by the 36-hour or 48-hour point, and just like quite a dramatic turnaround. And it's not captured in the data, but sorry, Zain, if you could.
Yeah, I would 100%. I mean, the Weinrich trial actually did say people that had a 4-day better symptom resolution, but it is remarkable, and I will agree with you, Anil. Like, we have very high risk patients who feel miserable. Those viremic symptoms, like the fever, myalgia, fatigue, lethargy, diarrhea, GI symptoms, they evaporate. The cough does tend to be persistent, and that's probably just same as a post-viral cough. It takes some time as it's more inflammatory than it is infectious. And we've had people walking in with sats of like 92%, where I'm not sure how they're going to do. And we just kind of give them the mAb, tell them to take a home O2 sat and keep tabs on themselves. And I call them a week later and they are, feeling back to normal in that sense. We've had 80-year-olds we've infused who are unvaccinated, who I look at and say you have a 30% risk of ending up in hospital, who at the end of isolation are back out in public. So yeah, it is pretty remarkable how well people feel at the end of it. And I don't think I appreciated that until we started treating people aggressively.
Perfect. Thank you for that. And do you foresee, either of you, in terms of the new treatments coming out from Merck and Pfizer, do you foresee that being a game changer? They've been touted like that in the media, considering it's within 3 to 5 days and we're not sure regarding Omicron.
Yeah, I mean, I think, their mechanism of action is not spikes, so hopefully should be preserved in Omicron. The Merck drug was more disappointing once the final analysis came out at its efficacy. I would still say, there is probably roles for settings like long-term care facilities where we know outbreaks can happen, and getting people started very early on treatment may mitigate the disease, especially with maybe an anti-inflammatory like fluvoxamine. There's still probably real benefits of having that drug available. The Pfizer compound does look legitimate, and I think, again, would be a nice option. We do know, with Omicron, we're going to see a lot of vaccine breakthroughs in 70 and 80-year-olds. And so again, many of us are starting to think, okay, what are we going to offer that patient? mAbs may not be the appropriate option. And so, that might be the option for that person that we think on, they'll probably do fine, but we're always a little bit worried about those 70, 80-year-olds who are fully vaxxed, who have a breakthrough case. This might be something to offer them to say, okay, we're going to reduce the risk even further in that population as much as possible. But, there's going to be a huge global surge for these treatments. And so, we'll likely not have a very robust supply for the first few months of this. And so we're probably going to have to be particularly picky about the people we pick to give these treatments to, recognizing that it has to be the best bang for the buck patients. It can't be the lowest risk patients in that sense.
And just a question regarding long COVID, is there any evidence for any of these medications showing reduction in terms of long COVID, or is it too early?
Yeah, too early. I mean, again, as Anil and I had mentioned, people do feel a lot better at the end, which is likely a good sign. Having less hospitalizations, less severe disease. We know severity is associated with long COVID. So again, that may be an issue. Certainly some of the patients I've followed up have had some residual symptoms at the end of their COVID-19, but again, had been remarkably better after being treated. And so, I think probably there is going to be a reduction in that standpoint. We know it probably, shutting down inflammation probably has effects on long COVID. And so, I would suspect that treatment would be helpful in that sense.
And, considering we're looking at mAb treatment for early and mild disease, plus one risk factor in immunocompromised or unvaccinated patients, do we have currently the resources to treat them? And is there space in the clinic right now? Or do you foresee that we have to try to save these medications for Omicron?
Well, Omicron's here. I don't know. So there's no saving anymore in that sense. I would say, like we need to burn treatment. Well, treatment doesn't work when it's sitting on the shelf. That's why we started the clinic. We would rather save every healthcare bed to patients that need it. Our barrier isn't necessarily patients, it's patients being identified early and being in the window. Again, every patient I see that shows up with 12 days of symptoms that's going straight to the ICU and getting their test on admission is a failure for us, because we could have probably intervened for some of those patients earlier and kept them at home and had a recovery and not dealt with the healthcare issues in that sense. So, I think, again, we just need to burn treatment as fast as we can and use it to save healthcare beds, especially in the Omicron wave. And the more aggressively we get out there, the more we educate patients about this, is going to be positive for us to get people diagnosed early and hopefully treated early in the process, especially as we scale up.
And there've been a number of U.S. reports regarding home IM mAb treatment or IV treatment. Have you heard anything in terms of home-based treatments here in Ontario?
Yeah, I mean, we were working towards getting a subcutaneous Regeneron program going, and our one fear had always been something like a shelter, which explodes, that we could go out to the shelter rather than getting shelter patients here. It With this Omicron data that's showing up, it's probably not going to be a possibility. And so, Sotrovimab, the only data we have is intravenous at this point. There have been home care agencies. I know my colleagues in Alberta and Saskatchewan have been using paramedics to help with delivery and doing kind of reconstitution right in the ambulance. So, there is possibilities for it. Right now, we're trying to just get aggressively to as many patients as possible, but absolutely, as this expands and people are accountable for it and people are willing to pitch in for supervision, it would be great to use paramedic and ambulatory services to get it to homebound patients, shelter patients, long-term retirement patients, and not bring them out of their settings to come here. We've had to bring a couple of high-risk institutional patients to us, which has been a total pain on them and others to organize. And so, even we recognize that it's not a great model for them to come to us in that sense.
And can you speak, sorry, Dr. Chagla, putting you on the spot a lot, but, just in regards to access of mAbs outside of Hamilton currently, how do we, if the patient's a bit far away, what are the options available?
Yeah, there are small programs that are kind of ad hoc programs that are being run at Humber, particularly for immunocompromised transplant patients. There have been a few doses being given at Trillium through Christopher Graham through their assessment center. And London, I think, has also had a few programs that have gotten a few doses in through their collaborations with public health. Sudbury has given Sault Ste. Marie has given a few doses in their emergency rooms too. So there are little ad hoc programs. It might not be unreasonable to kind of knock on the door of your large regional referral center and see what's going on, because they might have the ability to kind of do that emergency room dose for the odd patient. And there are discussions and a plan to expand this to more sentinel centers that are running kind of our type of model of large scale clinics in that sense.
And there's just a follow-up there is that, and it's more of an opinion based, why aren't more facilities doing this? Is it access to medication, not having the dosing? What's the current barrier for this?
Yeah, there is a bit of an inertia. Everyone's burnt out. It's hard to run this off the side. Having nursing support, pharmacy support, digital support. We've been, digging deep into our public health units and our assessment centers to get patients. All of that took time, effort, resources, funding to pay for that staff. And even with vaccine deployments, it's been tough to staff, all the time. And so I think that's been the big barrier to just breaking through. And that's, again, why we started the pilot clinic to work through the initial kinks and kind of get that first experience to get out there in that sense. But I think that's been it. Again, other provinces have also had difficulties kind of jump starting, mainly because of patient education and again, getting the doses in within the time interval. And so, again, this is an emerging area that I think many know about, but it's just been hard to kind of break through the ceiling of getting going in that sense.
And the youngest patient that we can treat with mAbs currently?
The EUA is for 12. We have done a couple of people under the age of 18. We're obviously not the most comfortable with that because I'm the one supervising, and that, I haven't seen a child in a long time. And so if there needs to be a resus issue, then there's a problem there. I think we're recognizing that we could probably deal with teenagers okay, but I don't think we would go under than 12 just because of the lack of, St. Joe's has neonates, but we don't have a true pediatric resus service. So it's gonna be difficult in case we have a severe reaction in a teenager or younger than a teenager in that sense.
And is there any data on benefit in vaccinated patients with severe disease as well?
So this is an emerging area, and so Regeneron does have a data set suggesting that there still may be benefit in some breakthrough patients depending on their age. They actually used the scoring system based on comorbidities and age, suggesting it. Now, I always take a grain of salt because that's from the company itself. When you look at the inpatient data, there is no benefit to giving it to people who have pre-existing antibodies, whether they be from prior infection or from vaccination or from the fact that they developed antibodies to their current infection. So, it is a bit mixed in that sense, whether or not these will actually work well in that age group, which is why we chose immunocompromised as the people that would likely not have antibodies or have very poorly functional antibodies in that sense. Omicron does change a little bit. And so again, this is data that probably does need to be updated, or at least observational data that needs to be put out for Omicron. Certainly US centers have been giving Regeneron to vaccinated individuals with risk factors. And so, again, it might be, right now we're not taking a lot of high risk vaccinated with immunocompetency, but it may change, especially with Omicron, as neutralizing antibodies are much lower. And so, this may be supplemental treatment for those people that are, poorly vaccinated to Omicron in that sense.
And have you, either of you, seen any major reactions in terms of treatment, resuscitation type things? And a follow-up to that would be, do you think that we could do this in a regular family doctor's office if we had the resources to do so? Could this be a primary care-led solution if possible?
So I'll comment to that. So I am a family practice doctor. We were able to do it in our office. We had, a special entrance and lots of precautions, and tried to do it off hours, and, lots of challenges, but we were able to do it. Now, so far as reaction, we would have had, I'm estimating 51 get active treatment. Some got placebo in the study. 50 to 51 would have got active. And really we saw nothing, no adverse effects. Some people were cold as they were being administered the IV medication, the sensation of being cold, but nothing. So no other significant reactions, and really positive at the 24 or 36 or 48-hour point.
Yeah, and similar with 60 doses, we haven't seen anything. And the only issue has been people showing up that are probably needing to be hospitalized, which has happened a couple of times. But so that is the other buyer beware is, people don't realize their SATs are 85 until they show up. And so you may need access to a place to shunt those people to if they do show up in that state.
And there's a couple other questions. Do you mind staying on for a few extra minutes? Thank you. And if anybody needs to drop off, totally understand, because we're past our time. It's 9:04 right now. And again, thanks to everyone for tuning in. In terms of post treatment, how long do we have to wait in terms of vaccination?
Yes, it's a good question. So the current recommendation from the CDC is 90 days. We have been giving exemptions in the clinic for 90 days for people. This is on the basis of prophylaxis data plus, expert opinion data in terms of when people have antibodies clear enough to be able to make a reasonable response to vaccine. So right now it's day 90. Again, that may change. I saw a paper in Open Forum Infectious Diseases suggesting people could make a response by day 28 in those individuals in that sense. So right now we're day 90, and this would be one criteria to give a ministry exemption for vaccination for the fact that they probably do have some protection at day 90, and they may not make a great response to vaccines for that first 90 days.
Anil?
So I'll just answer that in a different way. That you asked when can they be immunized. I'll rephrase that. When do they need to be immunized potentially? Because so with the follow-up study we did in IM versus IV Sotrovimab, we received, we just got a memo that at the 6-month point there's still antibody present, and so perhaps they don't need to be immunized until that 6-month point, and that analysis is ongoing. So they may have longer term antibody protection.
And is there any evidence for decreased transmission of virus? So let's say someone gets treated.
Yeah, absolutely. So viral loads go down. We know that, and so their viral loads drop faster than people who receive placebo, and that often goes to symptomatic improvement. So theoretically, there would be decreased transmissibility for those people who are treated early in that sense.
Okay. You know, again, I'm just going to say thank you to both of you for taking the time. There's a question again regarding whether this was sponsored. I just want to reiterate, this was not sponsored in any way whatsoever. Our speakers were not paid to attend tonight. They did this out of their own free time. So I really appreciate both of you agreeing to do this. Just to summarize for everyone on this call, you know, we know that there's treatments available now, and these treatments are free to our patients. If we identify them within that 7-day period, the earlier the better. New treatments are coming in terms of medications, pills that we could possibly give within 3 to 5 days of those patients with symptoms. As physicians, it's our job to try to identify these patients and try to advocate for these treatments as soon as possible, especially when we're looking at these monoclonal antibody treatments and such a low number needed to treat and no cost to the patient. So again, just want to thank everyone for attending and you know, wish everyone good luck in terms of the next wave that everyone's talking about. Please take some time out for yourselves during these holidays. As we know that this battle is ongoing, although we are in a better state than we were. It doesn't feel like it on a day-to-day basis, but we're definitely in a better state than we were a year ago. And thank you again, Zain and Anil. Really appreciate it tonight.
Thanks, guys.
Thanks, so.